Shall we please take our seats as we get ready for the third plenary session of the day? So, for the third session of the day, we are going to consider the topic, are our roads worthy? As your car is roadworthy, is the road worthy for your car? Innovative road design strategies for reducing traffic injuries, integrating safe system principles into urban infrastructure. And to give us this lecture, or this session, we have a very distinguished gentleman in our midst. He is Reverend Professor Engineer Eric Ofosu-Antwi. He's a civil engineer by profession, an associate professor at the University of Energy and Natural Resources, and the founding director of the Regional Center for Energy and Environmental Sustainability. As the first academic staff member appointed at the university, Prof. Antwi has shaped the university's journey since its inception and has taken on various key roles at the university, national and international levels. Prof. Eric Ofosu-Antwi was the head of the UENR's first engineering department and has acted as director of works at the initial stages of the university. He just ended his tenure as the president of the University Teachers Association of Ghana, UTAG, where he was regional chairman for the Ghana Institution of Engineers from 2015 to 2020. He's an international consultant who has consulted for key institutions such as the World Bank, the Africa Development Bank, the Ministry of Sanitation and Water Resources, the Ministry of Local Governments, and the Water Resources Commission. He is also a member of the team that wrote the new Ghana Water Policy in 2024. He has conducted several trainings on disaster risk management for the Meteorological Services Department, the Hydrological Services Authority, and some selected municipal assemblies in Ghana. He is a visiting professor at the best university in the world, which we now all know is the Kwame Nkrumah University of Science and Technology. He also visits at the Abdul Mumuni University in Niger and the Chandigarh University in India. As a prolific researcher, he has published over 60 peer-reviewed papers and books, placing him among the UENR's top 5 researchers. In recognition of his outstanding leadership, Prof. Ofosu-Antwi was recently named the Best Center Leader by the World Bank and the African Association of Universities for his visionary leadership. With a round of applause, shall we please welcome Reverend Professor Engineer Eric Ofosu-Antwi.
Thank you very much for inviting me, and thank you for the introduction also. I'm a Pojoba, and he was my senior in school. Let me appreciate the leadership for granting me the opportunity to be with you. I believe that we're going to have a very interesting session. Your conference is timely, and I pray that we'll have a very good take-home message after my presentation. I want to salute the president, who is my own brother. He was my best man at my wedding, so you can understand. Thank you very much. So I'm talking on our roads, are they worthy? And we'll look at innovative road design strategies. I have about 20 minutes, but I'll take time to digest this within the 20 minutes, trust me. So we look at road traffic accidents, and we see that it's any injury that we have due to crashes originating from terminating with a vehicle. And it is disastrous. It results in considerable economic losses to victims and the nation. And if you look at the impact of our road designs, it contributes significantly to preventable deaths and injuries. And every crash represents either a change in the life or a loss in the life because of the injury. Human mistakes are inevitable, but safe road design can prevent them from being fatal. So we can make mistakes on the road, but if we design the roads thinking of all these possible fatal things that can happen there, we can make it safer. And unfortunately, we lose about 1.19 million people across the world due to road designs every year. But this is not just statistics. We are losing fathers, mothers, and children. Close to 1.2 million people every year. So in Ghana, it's a daily reality and is a leading cause of death and a major public health burden in this country, road accidents. Traditional road designs often prioritize vehicle flow over safety, and it increases the risk. We think more about the flow of the vehicle than the safety of the people that are using the roads. And in Ghana, pedestrian knockdowns are common. It shows lack of local roads are unsafe for all our users. And this crisis is even more amplified now because of rapid urbanization and vehicle growth in our cities. If you look at these statistics, you'll see that from 2002 to 2024, the gray one represents injuries, death is the orange, and then blue is the cases reported. We are not seeing any drop. This one is 2025, January to August. So if you look at it, close to 16,000 reported cases, and look at the death rate, above 2,000 annually. And this year, we are just in 8 months, and we are close to 2,000 already. So the death rate is very high. And if you look at pedestrian knockdowns, okay, over 2,200 every year. So we are really having a serious challenge at hand. And almost all these cases, they run to your hospitals, and you are the first people to receive them. So you have, cases that come to you almost every day. Now, look at the rapid urbanization and vehicle growth in the country. 2023, we had about 2,400 vehicles. 2024 was a little low. I don't know whether it was because of the dollar, but 2025, things have gone up again. But rapid urban growth in urban cities lead to more vehicles on the road. Increased traffic density raises the risk of crashes and injuries as well. And our roads often lack sidewalks, crossings, and safe infrastructure for pedestrians. And the growing urban traffic highlights the need for safe systems in design principles. When you look at the statistics in Ghana, about 90% of our transport system is by road. Okay? And the road crashes are huge. This year alone, we have 9,626 road crashes reported, with 7,900 vehicles involved. The fatalities is just less 2,000 between January and August. And pedestrians who have been knocked down in excess of 1,000. But then we have an SDG goal to achieve. The target 3.6 says we should try and reduce traffic death by 50% by 2030. But if you look at the trend at which we are going, we are nowhere near what we have set as a road target. So now we're going to look at the problems with our traditional road designs in the country. We have highways interacting with other road users. And when I was in the university and we were being taught civil engineering highway, we were told that we have to let highways go through towns so that the towns can develop. But that is a recipe for disaster. You never see this in the developed world, so it's totally wrong. Prevention of pedestrians and other road users from crossing highways. We must design our highways such that nobody crosses the highway. But see Tema motorway, it's horrible. When I see people running across the motorway, I ask myself, in Ghana, what is wrong? Perpendicular intersections on highways. This is another terrible thing that happens. I'll show you. A lack of dualization of our highways. I mean, we need to prioritize this seriously. I mean, if for so many years we cannot dualize Accra Kumasi, then I don't know what is wrong in this country again. Inappropriate speed humps. Most of our speed humps are also death traps. Poor maintenance on the highways. Then the lack of illumination on our roads. This is the cheapest thing we can do in our road designs. And lack of warning signs, road signals, and reflectors needed to give motorists adequate time for making decisions on the roads. All those ones also do not exist. And then we need to have the separation of road users in our road designs. So we'll take them one by one. So this is a highway. Okay, highways are not supposed to go through towns. And even when they don't go through towns, they still provide nets, wire meshes, such that pedestrians cannot cross onto the highways. You prevent pedestrians from crossing onto the highways. And I'm sure most of you travel. You'll see it along the highways in almost all these countries, South Africa and the rest. It's preventable. You don't see any pedestrian trying to cross a highway because they are not supposed to interfere at the speed at which people are moving. Likely, you are not supposed to have speed humps on highways. It's not supposed to be there because of the speed at which we travel. But because we pass our highways through towns, okay, Kumasi, Accra, you can, plenty, okay? And so you brake, you stop, you brake, you stop. It makes the driver very tired. And some of these speed humps, we'll see, there's no sign for you. Even when a highway goes through a city, it is usually on these interchanges, such that it has no interference with the activities within the city. So, for example, we take the Accra-Kumasi road. So, if you reach Edwiso, okay, and you are coming, okay, the highway should be such that nobody should be able to enter from Kwamo or enter from Fumesia. You should be able to travel through. Okay, and I think one of the designs that they did right is the Ofanko Achimota one. Okay, no one is able to enter, and you have laybys that you can walk through, you can use your service roads for. So that is the kind of design you should have for a highway. So, I mean, to travel through Kumasi, you don't have to call Edwiso through Anloga Junction a highway. It's no more a highway, even though it's constructed by the Ghana Highway Authority because of the kind of interactions that is happening there. So this is how highways are. When they go through cities, we make sure that there's no interference so that the speed at which the vehicles move can still take place. Like I said, we have these wire meshes to ensure that human beings do not cross. But you see that even when we provide them at Tech Junction, the pedestrians will still break through because they don't see why we are protecting them. And then one critical thing is that if we do our urban planning well, we will locate highways such that you provide exits and entries into the towns and the cities. So when you travel on the roads in the Western world, you see a lot of these things. So usually these ones are exits into the city, and then we have entry points. Okay, so the highway is somewhere behind the city, and then you have an exit into the city. And by virtue of that, when you are coming back, you enter again into the highway. And that gives you a lot of prevention of accidents. Okay, so we have to integrate the road networks with the planning of the city. And unfortunately, we are unable to control the growth of the city. If you look at the way we are growing, laterally, okay, we are not growing by high rise and the rest. So by the time you realize, even if you put a highway behind the city, people will move there. People will move there. But we should be able to prevent them from crossing the roads. There should be a deliberate attempt to protect lives. But unfortunately, one of the things we see in this country is that we don't value lives. So we leave everybody to behave anyway and die and go. But if we really value lives, we will do everything to prevent people from dying. Even when you want to kill yourself, we should not allow you to kill yourself. That is what our road design should be like. And I want you to look at this very carefully, okay? You see somebody is coming from the town to join the highway. Now see this design, okay? We give the person ample road length to be able to pick up speed and join, okay? But unfortunately, see what happens here. Senior, this thing, it's suicidal. T-junction on the highway, killing a lot of people. There's one particular spot along the Mampong Road, Agona. Okay, from the hill, it descends. Several accidents do occur there with the trucks. This is exactly what happens. I mean, as an engineer, I should be able to think of this and prevent it. So if somebody has to join it should never be a perpendicular connection like this. This is what you need. Okay, you are trying to join. So I'll give you opportunity to take off with your speed. Okay, and by the time you gain speed, you are joining the main road. Okay, that's how it is. And if you want to leave, exit the high speed, the highway also, we give you opportunity to exit through here. You take off and then you move on. But if somebody is leading you and the person wants to turn into this and you are behind, at once break, bam, then you don't know what to do. But this one will prevent such a thing from happening. And for me, every road that connects our highways should be blocked and turned into something like this. Even the Nkoko bypass, of late it has become extremely dangerous. There is a portion there where people are entering, okay, and crossing it. There's no care for our lives. The Western world would never allow this because you are going to kill people. And sometimes they enter and you are not aware and you are just coming. And I ask myself, how can we allow this on the highway? And you could easily construct an underpass and allow the people who are living on the other side to be able to go through. But this is a serious thing. Then you see the same thing at Insawam. When you are approaching Insawam, on the hill, you see the trotro people crossing the road. And people are on this top speed, 100 kilometers per hour, 120 kilometers. This is how we are dying in this country. It's crazy. Then we have issues at the intersection, okay? Now, I just want to go through this. Perpendicular intersections points on our highways are recipe for disaster. Exit and entry points into towns and cities are to be properly designed. There's a link between the planning of the towns and cities and the intersection points on highways. There are too many dangerous intersections on our highways, and they are causing several accidents. Illegal intersections and constructions along highways should be prevented. I had a typical experience in 2017. I had just taken my fresh car from Habo, driving to Kumasi. From Chichire towards Suhum, somebody had bought an industrial land along the highway and was creating his own road onto the land. So he had gone for some caterpillars and they were creating the road. So he started from the highway and it was a hill. So what happened was that it was a rainy season. So when it rains, the rain brings the mud onto the road. And this particular day, it was raining and I was coming. And the road had become so slippery. The mixture of the rain with the mud. Every friction was gone. You press your brake, it it just threw me straight into an articulator truck. A fresh car from Harbour. My wife even had not seen it. Charlie. And it was crazy. Unfortunately, the following day I went there to go and pick some parts. And then I went to Abusuokai to go and buy. Then the shop I went to, I described my accident in a spot to the guy. And he said, look, the week before yours, he met an accident there. 33 people on the spot. Same scenario. So I called Highways and I said, come and see something here. Fortunately, I'm an engineer, so most of them are my mates. I said, please, there's a serious disaster happening here. If you don't come, why should we allow someone to just start a road close to a highway? I mean, this is how we are dying in this country. And it's crazy. God help us. Look at what happens at our intersections. It's one of the spots where we record a lot of accidents. A lot of accidents happen at our intersections. And I mean, we would have lost my brother this year just around an intersection like this because a lot of traffic lights in Kumasi are not working. Then, dualization of our roads. CO. This is how we design the roads in Ghana on our highways, and it becomes so dangerous for us. In fact, we are the best drivers in the world. If you look at what we go through, we are the best drivers in the world. It's disaster. This is best, okay? But who would drum this home? Who would drum this home for our leaders to see the need for us to dualize all our highways to save lives? I don't believe any road is more expensive than a human life. That is how we must think. The dualized highways can be designed with 2 or more lanes, but 4 lanes is the most common. The primary advantage of a dualized highway is that it reduces the risk of head-on collisions and side swiping. It permits traffic to proceed quickly and efficiently with the faster vehicles more safely overtaking slower vehicles traveling in the same direction. It prevents impatience in drivers, which compels wrong overtaking. Of late, we have become impatient because of the long tracks from Accra to Kumasi. And especially because of the condition of our roads, the tracks create more traffic, like the name and the rest, okay? Just a small problem with the road creates a lot of ripples. The long tracks are unable to move fast. So if a 3-4 hour journey takes you 7 hours and you become an impatient driver. So the least chance you want to overtake, and then you are leading to yourself to death. And this is what is happening. But when you get on the in Koko bypass, you are like in heaven, okay? And you begin to move very fast. But that is something that could have been provided normal. Another disaster is this one. Street lightning. Imagine traveling on this. If there is any damage or any accident or any breakdown or any pothole, you would not see it. But this is the cheapest we can do. To incorporate street lights in our road designs is the cheapest we can do. And it should not cost us much. And for street lighting, it has been as a relatively low-cost intervention. It may improve a driver's visual capabilities and ability to detect road hazards. Okay, it prevents vehicle lights from disturbing oncoming vehicles at night. Sometimes it's your highlights that can help you see well. But once you switch on your highlights, you're also disturbing somebody else. Then when you put it off also, you are going to die. So what do you do? What do you do? So now people put on their highlights and will not think of their oncoming brother because he doesn't want to die. Then we come to the speed harms. Crazy ones, eh? Now this has become job for the boys. Anyone goes out there and say, I'm a contractor, and they build speed harms that are never engineered. The unfortunate side with our speed harms is that they have the same color as the road. So when you are coming, you don't even see that there is one. And there's no warning ahead of you. And they are put on highways. If I'm an engineer, I'll say, it's not done. A highway should not have speed humps. But because of the shoddy work we are doing, and everything is about lack of money, but we are not prioritizing the human life. Okay, value for money, value for the human life should be added to value for money in our designs. Maybe this can be a take-home. We should not only look for value for money in road designs. What is the value for human life also in the design of our roads? That one, we never touch on that. And then these ramble strips are also creating a lot of havocs on the roads. And sometimes you want to run over it fast so that it does not slow you down. And that one is also another. So instead of thinking that people will slow down, we rather go fast on these ones, especially those with the 4x4. So you are rather helping us to speed rather here. Now, they have advantage of being largely self-enforcing, but speed bumps are generally installed to slow the speed of traffic in residential areas and school zones. Okay, they force cars to move at a slower pace. They can create problems for emergency vehicles. I am sure our ambulance drivers agree with me. What speed ramps does do to your trucks and the buses. So they are not meant for highways. This is the reason why highways are to avoid going through towns. Speed humps on highways are dangerous for both cars and pedestrians. Because if you don't see it well and you bump into it, you can skid off. And you might knock people that are walking along the road. Now, this is how it's supposed to be done. I took this picture personally on my time is up. Personally on Sunyani Road. When people put sand. With this, you see some markings you can see along. But let's look down here. This is a road sign. Speed humps ahead. Humps for 1 mile. Okay, there's a hump 1 mile ahead of you. It begins to warn you. 500 meters, 300 meters. So you have the warning before you reach there. This is how we should look at it. You see, this color is different from the color of the road. You have some reflectors on it. It helps you. This one also, you have some white markings, and this one is also a reflector in itself. These are some of the speed humps that we should look at. And then the traffic lights, the rates of road traffic death are highest in Africa. 26.6 people in 100,000. Okay, and Southeast is 20.7 in 100,000. 58% of fatal car accidents involve only one vehicle. 38% are caused by traffic collision. Each year, more than 1,600 children younger than 15 die in traffic accidents. And most traffic lights in Ghana are misfunctioning with no aggressive attempt to address them. You see how traffic lights are being regulated in some countries. But here, you see the motor rider, and he's like he has not seen a traffic light. And he moves on. Pedestrian overpasses and underpasses. Looks like in Ghana, we only know of the overpass, but we don't know of the underpass, which is even cheaper. But we hardly do that. And it's... Sorry. Oh, it looks like I was pressing the wrong one. So we should rather think of underpasses. It's cheaper than the overpass. This one is so difficult to climb, but you can easily create a small rise, put this under, and everybody will go, and there'll be no interference. And these simple designs also, we cannot even do this. Oh, God. More than half of all road deaths are among vulnerable road users, pedestrians, cyclists. Road traffic injuries are now leading cause of death for children. And then look at the chaos here. Motor pedestrian routes. Look at this and look at how orderly this one is. We have the highway, we have the motor, we have the pedestrian. But so see this one. Okay. It's President Kufuor who started something like this in front of the Legon Road, okay? Yes, the Legon Road is almost in this, and I wish that other leaders could just continue in that way. So motor, pedestrians, and cyclists represent 26% of all deaths, while those using motorized 2- and 3-wheelers comprise another 28%. Car occupants make up 29% of deaths, and 17% are unidentified road users. So these are some of the road transport accidents preventive structures that we can look up to in this country. Let me do some engineering a little here. Alignment, vertical and horizontal. Please, you see, this is a natural terrain, eh? This is a natural terrain. Okay, naturally. But if you want to construct the road, we are supposed to turn this natural terrain into this, so that your sight distances in traveling will be good. Unfortunately, I don't know is the engineers whether they are lazy or what, including me. We create something like this, and the sight distance is so poor that if you are traveling at 80 kilometers per hour, you don't have enough sight distance to be able to see an oncoming vehicle or brake. If you have used the Sunyani Techiman road, it's one of the worst designed roads in Ghana. It's a recipe for disaster because the sight distances by the vertical is very, very poor. Then we have the horizontal also, okay? The curves, okay? We have the vertical and then the horizontal. You need to create the curve such that it is not too sharp, okay? So that you have sight distances equal to the speed that you have designed for the driver to move at this speed. So that if anything is ahead of him, he can see it in good time to brake. Okay, this is how our roads are supposed to be designed, and it's very critical. So you see, accidents occur in areas where enough sight distance have not been given because the curves were not engineered properly. And then the almighty potholes that happen to us. Interestingly, Rwanda has a 72-hour pothole policy. No pothole exists more than 72 hours in Rwanda. How I wish that Ghana could have something. then one man to crank the boy. Case study. Sweden has a Vision Zero road safety strategy established in 1997 to eliminate all fatal and serious traffic injuries. The main purpose was to shift from reducing crashes to preventing deaths and serious injuries, assuming human error is inevitable. So you can make your mistake, but there will be no death. That's how they are thinking. Safe system road design, separated lanes, traffic calming, lower speed limits, traffic fatalities reduced by 50% between 2000 and 2040. So they achieved something great. Okay? Vision Zero is achievable with commitment and design innovation. What are some of the innovative strategies I want to put across? I'm wrapping up. Ghana needs its own version of Vision Zero policy on accidents. Incorporate street lights in all roads, especially solar street lights. It's easy and cheaper. Perpendicular intersections on our highways should be redesigned as a matter of urgency. Urban road design should separate road users. The National Road Safety Authority should be well-resourced to enforce road safety measures promptly. I think the money should go to them rather than going to the highways so that when they see the problem, they can address it. And for me, it should be decentralized to the municipal and district level in the medium term to be much more effective. They are at the regional level, but the region looks too big if they really want to identify all the issues. And I want to encourage EMSOG to be a strategic partner of National Road Safety Authority. I looked at their profile, and EMSOG is not a partnership there. Even GMA, Ghana Medical Association, is not a partner. I saw Red Cross. But I also looked at their board membership, and there was no medical doctor on it, and I think it's a big mistake. You receive the cases direct, and you can speak passionately to it and ensure that something is done right. So EMSOG should have a permanent seat on the board at the national level. Please push for it. And they are proposing a district road safety committees. Please push and also be members of the National Road Safety Authority District Road Safety Committees, because you are receiving so many cases and you can be able to push that, look, the records that are coming shows that this is where things are happening. Please go and do something about it. And our takeaway message, I want to quote Mark chapter 8, verse 36. What profit has a man if he gets all the world with the loss of his life? You make all the money and you die on the road. It doesn't make sense. So please, we must invest in protecting our lives on the roads, including the politician. Road traffic accidents are man-made. Too many deaths are occurring due to the wrong structural designs. The road designs in Ghana must be reviewed to incorporate several preventive structures, and the NRA should be resourced and empowered to fix all potential accident spots. Ghana should have a Vision Zero policy, and EMSOG should be a strategic partner of NRC. Thank you.
Thank you very much, Prof. See, there's a little bit of the engineering. Then, of course, as he's a reverend, we had to get a little bit of the Bible as well. Please, are there any questions for him? So please, you can move to the middle.
Prof, thank you for the wonderful presentation. Mine is not a question, but I think I want to just add something to your example so that if you happen to stand anywhere, you can speak also for us. I think between the Santasa roundabout and Ahondo roundabout stretch, just when you reach TUC, the newly constructed road, it branches straight into TUC, and there is no pedestrian walk. There is no bus stop, nothing, and that is a community. And what's the name of that school? State Experimental. It's just around that side, and every morning you read there and you see children trying to go to school, and they are walking in the road, and pedestrians who want to go to town and Sofola and other things are boarding and off-boarding cars in the middle of the road. So at night, it actually becomes worse, because if you are not a regular user of that road, a truck driver might just stop in the middle of the road and you wouldn't know. A car might want to enter to TUC or exit from TUC, and it's just too bad. I don't know if maybe from your engineering perspective, that's how it's supposed to be per whatever principles that you have. Because other than that, I think growing up, I grew up around that side, and Dakodum route used to be a hotspot for road traffic accidents, especially for the school kids. I think government tried to do something about it, and I think that design, we are just sitting on a time bomb. I don't know if we want to see 20 students die again before we visit that side.
Thank you very much. That's a very valid point. Thank you. So I think Prof has taken note of it, and he will keep track of it so that when he gets to the appropriate quarters, he will forward our concerns. Please, any other questions? Hey, yes, please.
Prof, you have done well. It shows you went to Pope John. You have said he was here. But one issue, I've stayed in Tema for 20 years now. And I for almost 10 years, I travel on the motorway twice a day. And so the motorway example you gave is right. No lightning. For 20 years. Governments have tried. They put it there, Shaman boys to come and remove the cable. So as of now, there's no lightning. Even in Tema, if you climb, those who know Tema, if you climb the motorway entering Tema, there's a particular traffic light that will right to go to Ashama, left to Tema. It has spoiled for 8 years. That traffic light, 8 years. So I don't know. My issue is that we have seen that road contribute a lot to this man. He's my friend, so I call him CEO. They are response time. The last time you have an issue on emergency delays, we realize that it's not about the distance. If you have a bad eyes view, you can see that maybe from one side to another side alone, it can take the ambulance 1 hour. Even in normal sense, it would have been 5 minutes. But because of traffic, because of the road nature, it contributes to the delay in reaching out to care. So, as we are here talking about emergency and delay, you are the one in the engineering. What do we do? So that, because we can't fix the delay here. What do we do? Thank you very much.
Thank you. You see, the world is advancing. I don't see why we should connect cables to do street lights when we have solar. Okay? But unfortunately, the kind of solar street lights we fix, I ask myself, so what kind of engineers go and fish for these solar street lights? Because we have now modern solar street lights that have lithium batteries. So you don't even need to see a box carrying batteries on the street light pole. And they last long. If you come to my house, I have 2 of them. They bright more than even the ones on the street, but they are not expensive. So you can easily fix these on the poles, and you will not get a shaman boys to go and remove them.
They'll find a way.
Okay?
They'll find a way.
Because it's up there. Previously, people were thinking of the battery, and if you bury the battery, it will not last long. So some will try and fix some metal cage, and then the battery is in there. Those batteries don't last. Now we have lithium batteries. So that is why I'm saying that it's very cheap to have solar street light. And that one, you are not consuming electricity, so that they can even take away solar street light in our electricity bill. You know, there's a street light in electricity. They should take it out, okay? Because when you go solar, we are not paying anymore for street lighting. That is the way to go. But for the Temamoto way, I hope that the reconstruction will help save the situation. And when they are done, they should not allow T-junctions into Temamoto way, nor people crossing it. That one, in the 50s, it was not there. Even in the 80s, until recently, it looks like this generation has become a little bit, I don't care, and we are allowing all these things to happen. So, brother, this is what I can add. Thank you.
It looks like the post-conference communique that EMSOG will send to government is going to be very heavy, very, very loaded. Thank you very much, Prof. So, for the next plenary session, we have one of our premier paramedics from the National Ambulance Service. It is my honor to introduce Mohammed Najib Mahama, a paramedic specialist with professional training and experience in both Ghana and the United States. He began his career with the National Ambulance Service of Ghana, serving across multiple regions and contributing to frontline emergency care and training. He advanced his education in the United States, completing an associate's degree in paramedic studies and qualifying as a nationally registered paramedic. He also holds a master's degree in clinical trials from the University of Ghana. It's not KNUST, but we'll take it like that. Mohammed Najib has practiced in high acuity emergency services systems and continues to support emergency medical service development through education, curriculum development and improvements, and system strengthening. His work focuses on improving emergency care delivery through strong clinical practice and capacity building. With a round of applause, please let's welcome our paramedic specialist, Mohammed Najib Mahama. Oh, please let's keep clapping for him.
All right. So, welcome once again. Today we'll be doing emergency care as a system, integrating pre-hospital facility and policy responses to Ghana road traffic burden. So we want to see how the systems come together and how they should work together. So National Ambulance Service, that's where I work. So just going to give the background, 2004 ambulance service was formed due to the disaster that we already spoke about. We started with 7 stations, and then we expanded to all regions, and about 300 ambulances across the 16 regions that we have in Ghana. So you can see that we permeate the length and breadth of Ghana. Basically, we respond to 122 calls. I don't know, the thing is going off. Okay. We respond to 112 calls. That's the roadside or in the houses and all that. And we do also pick people from one hospital to the other for further management. And in terms of emergencies, disasters like the June 3rd disaster, we showed up in mass casualty incidents and natural disasters and things like that. And we are always part of it, playing our role as the ambulance service. So most of the things I've put up, they've said them already globally. We all know the burden of death, what is happening. But what I can emphasize is that about 19.4 deaths per 100,000 people in Africa. So it means that the African death, proportion, when you compare to the world, is higher. Even though when you compare, you realize that in Africa, we have fewer vehicles per the people. So it means that we are not doing well. In Ghana, there is an estimate that we could hit 31 per 100,000 population death. So that's not good for us. Keep going back. All right. Most of the things already, because our previous speakers, they kind of spoke about them. I'll keep skipping them and then tell you what I want to. So currently, why? When I click, it doesn't come. When I double click, it jumps. Please, can you help me? Otherwise, I'll just use my hand on it. No, it's not a battery. Are you the one? Yeah, please help for me. It just came to, it jumped. No, not there. Yeah. So this is back. I should do it. Okay, I'll just use this. All right. Okay, emergency response. How do we respond? When there's an accident, how fast can we get there as a service? I think I jump 1, 2. Because he jumped, yeah. This is where I was? Okay. So, yeah, so we were here. So how fast can we get to the scene? Already, my boss spoke about it. It's about 25 minutes for us to get to the scene. But this number, just like he spoke, we may have to look at the way we do the calculation. Because what we do is that we kind of pick the number from all the cases. Sometimes they are just hospital, transfer. But going to a hospital cannot be described as a response to a crash scene, but because we haven't segregated. But then you realize that in other jurisdictions, in the UK and other places, what they do is that, let's say in Ghana, what we strive to get is between 9 to 10. We want to get to the roads between 9 to 10 minutes. But then they calculate the proportion of cases, that falls within the target of 9 to 8. So that way, when you do the calculation, it will not be calculating a mean response time. When you have outliers and you do mean response time, the longer ones skew it and then give you a false response time. So the 25, we may be doing better than that. So next time we'll come with either the proportion, of cases that are within the 8 to 10 minutes so that we can tell you something better in terms of how we are doing. Okay? So, all right. So if you look at the average response time, this is region by region. OT region, because the way is kind of long and stretched far, and we don't have, so there's a delay in getting to the scene, you can see that it's an outlier. So when you strike a proportion, OT region will skew the whole 10 and give us the 25. So that's sometimes what is happening. But this is region by region, what we are doing with it. Okay, when there is a crash, how do we respond? Usually we want EMS to be there, ambulance will run to the scene, go get the people, help them. Then we expect that the police should be there. They are always there, and fire service. So otherwise, you get to the scene and you are working on the patient, another car will come, veer into wherever, clear and kill all of you. Usually, yeah, it happened before. I think somewhere, Bekwai, right? Those of you who are a bit old in the system, you realize some fire officers were working on a car and a vehicle came, cleared and killed all the people. So usually ambulance, when we go, we try to ensure that the scene is safe because we are more important than the people who are in the truck, right? Yeah, you are more important as a responder, as a human being. You don't want to die. So we make sure that we check our scene, and then we call the fire, police. Fire would come to block the road. They'll use their truck to block the road. And then if we have more cars, we'll block the other half of the road, and then we'll put police at the end. They'll direct vehicle through. So there will be huge traffic there. Usually it happens. But it saves us. It keeps us away from dying. Okay? Okay, all right. So that's that. So the fire would, so let's say there's an accident, right? The third point, and somebody is trapped in the car. We don't really know the stability of the car. We don't want to go into the car and try to work the person in the car. And the car will slide, through and crash. You have a double crash and you die. And sometimes when there's an accident, the battery and stuff are still connected, and you need to disengage all that before you get into the car, wedging the car, stabilizing. So you need fire service to do that for you, And sometimes the car is locked. You need to break the doors, get the person out before the EMS can work on the person. So fire service will be there for that. And the police will control the crowd because people will come to look. And then they'll end up stealing stuff, right? And sometimes fighting over the stuff on the scene. Yeah. All right, so these are some indicators, performance indicators we want to look at. So those that I want you to know. So the response time you can see here, there's one important thing that I want us to talk about, vehicle turnaround time, okay? So you see that we are doing around 40, 41, right? That's 2023. Currently, we are doing like 38. It means that when you get to the hospital with a patient, it takes an average of 40 minutes for them to get a bed to take the patient away from you. So the vehicle is... no, this is average, right? You see why? Yeah. So I'm coming. You know, I should have bring that of Konfuanachi, eh? Konfuanachi is 2 hours, an average. No, the average in our distance, it takes 2 hours plus, and then Western region, those are the highest delay times we have. But you see, these are skewed, like I've said, because we just kind of strike an average with, for instance, if you are in a village and then you go to the hospital with a patient, they will just take the patient, right? So elsewhere, what happens is that you have a patient in an ambulance and then you are coming, just like the minister told us. You would do a call to whoever is supposed to receive the patient, and then you inform them, you tell them about the case. So you will triage, and they'll give you a room. So you already know you are not going to triage or anything. So once you hit the ER bay, and then you get the patient out of the car, you wheel the patient right into the room. They'll bypass triage, you understand? So that's what they do, and we hope that we can collaborate and get to that level. All right. So coverage, you know. So earlier I said we all know the one constituency, right? One ambulance, right? And so we have them. But the challenge is that the constituencies are so big that certain parts of the constituency will never see the ambulance until the ambulance is done. Because it's big, you know, they cover a primary service area that you are, they won't see you ever. The ambulance will never go there. So I mean, literally, the constituency is actually not covered. Yeah. All right. So these are some of the challenges that we are facing. We have a limited coverage, delay response, which we spoke about, insufficient first responders. We just started. And then we've trained 6,000, just like my boss said. The last just went out this very month. And we would be posting them to the communities so that when there's a case, they can hold down the, the victim or patient, and so that EMS would come, take the patient, continue with treatment, take him to facility. They'll treat him there, and they'll come out of facility. All right. So this is a map that just illustrates. So wherever there's an ambulance, there's an ambulance. Can you see that? So that's the map. Wherever there's an ambulance, there's an ambulance. Yeah, the ambulance can be broken down anyway, but we will we'll come to that. Okay. So these are the hardcore figures. So you see that in Ashanti region, we have 47 ambulance stations. Then we have Greater Accra, second, we have 38 ambulances. We have Eastern region and all that, okay? So that's how we cover. So Ahafo, I know Ahafo very well, right? Just between Kukum all the way area through Totro, that's a big place. We only have 6 ambulances to cover, you know? And that's a very, very wide area. So that's woefully insufficient. Even though our map looks so clumsy and beautiful in terms of when we map it out. I should go back. So not all of it. It's fluid. You understand? It's fluid. So there are some some are out of commission, they are broken down. Not all of them. Yeah. Not all of them. Yeah. All right. But then you see, is between. So the facility, we don't want to have challenges with the facility as well. When the facility is doing everything good, EMS will be very smooth because we'll be able to hand our patients over to them for. So these are some of the things that we found in the facility, like fewer trauma centers and poor infrastructure, So in Ghana, it's quite difficult, especially classification of the hospitals, level 1, level 2 trauma registry. I mean, you don't really know. Sometimes, like, probably we need to do proper classification, make a trauma registry so that it's standardized. When you pick a patient and that patient deserves level 1 trauma, then you know that there's a hospital, this hospital gives level 1 trauma. And when you go there, these are the things they can do. If it's a stroke center, it should be designated as a stroke center capable hospital and be registered in a registry so that we have that information. So it will help our work a lot. Lack of, essential equipment. Monitors, sometimes you go to the hospital, they don't have imaging. So, okay. So imaging, right? For instance, you go with a patient who is having stroke, So they are very positive for stroke when you assess them. And then you go, you can't get CT scan. It means that the patient cannot be treated, okay? Essentially, you are just holding him the same way EMS is holding the patient. And it's not going to help the patient. So elsewhere, what happens is that when the patient is positive for stroke, you bypass ER, and then you go to CT straight, and they do it, you pick whatever, then the patient just goes into wherever they have to go. They have to go and do whatever they have to do, right? So like you pick with MI. If you are sure it's MI, there's a protocol for you to bypass ER and go to the cath lab. If you see inferior leads, elevations, reciprocal, like anterior lead depressions, and you are 100% sure that this is MI, then you can, bypass. So these are the things that we are working towards to bridge the gap. Staff shortage, we know that, equally same in EMS, just like we are saying, we only have a handful of paramedics in terms of that ranking in Ghana here. So, we are challenged as well. And the hospital, we don't have enough surgeons, anesthetists, we don't have enough ER physicians. Just we saw that referral, very weak coordination, the way we refer patients, We don't make adequate preparations. And when you refer the patient or when you are receiving the patient, you are supposed to be ready as a physician to give out medical direction. So medical direction, I pick a patient. Sometimes there are some medications, for instance, we operate with protocols. And some of the protocols, we have online and then we have offline medical direction. And the medical direction that is needed for the EMT to do the work should be given ideally by the one who is receiving the patient. Because it wouldn't be nice if I pick your patient and I give them diazepam and I bring your patient and you don't want diazepam on your patient, will you be happy? So you should give the medical direction. The medical direction should not come from any, it should come, you are receiving a patient, I call you, I have a patient, this and this, is having status epilepticus, whatever. I want to give them what? Diazepam. No, I don't want diazepam. Give them lorazepam. Give them some, you understand? Then I'll switch and give them lorazepam because that will help your work. If you don't do it, they call us, we give them the, what do you call it, the go ahead to give. Then when the patient comes, you realize that your work will be challenged. And that's not what we want. All right. So the policies, the minister is out, but the policies are hanging, right? So we speak about them. So in Ghana, we have a lot of policies. It's just implementation and enforcement. We don't enforce them. We don't really put an effort to implement the policies that we have, okay? You should not drink and all seatbelt, all these things we know, okay? We should just adhere and make sure that we don't get to all the serious things that they've taught us today, okay? Funding, we need money. We need to train. So we run a paramedic emergency care training squad in Kinkan. So we train the EMTs. They come out. And now we want to train people. We don't have money. So we want policymakers to assess the hospital, all stakeholders, so that we get data. Data is something that she's requesting for us to give data. Very important. So one day, 911, I went to 911. I just ran calls wherever I was tired, sat by the person who is engineering the 911. Now I was asking him a question, He told me that a call will come. And when the call comes, an accident, a case, somebody will get sick, they will call, right? And when the call comes, it will be coming from West Fargo, right? Lo and behold, a call came, right? And it came from West Fargo. And how did you know? It said data, you understand? So the more data you keep, the more they begin to generate patterns, and those patterns it's just like you throw a dice. The more you throw the dice, the more you can calculate the next time you get 6. You understand? So what happens is that they can dispatch you when there's no case. You understand? They can, 6 million, right? They can dispatch you for a case. Are you listening? There's no case. They can dispatch you to meet a case halfway when the case hasn't occurred yet. You understand? So you are on the way to the case, and then the case will come, and they'll tell you that there's somebody en route to the case, and you go and take care of it. So they just dispatch you when there's no case. And it occurs. Nobody knows why, but because the data is talking to them, they have patterns generated. So let's gather data, allow the data to talk to us. I know Dr. Nava is here to sack me. Don't worry, I'll not finish. I'll just conclude by saying that if we collaborate very well, all stakeholders, somebody dropped down, dying, right? We've trained community first responders. They'll be able to respond, do CPR, do whatever they can do, keep them in recovery position. EMS will heal all the way there, pick the patient, provide advanced life support to them, give all the medications, send the patient to the ER or bypass the ER as and when it is necessary, right? Then they take the patient, continue with the treatments. At the hospital, patient recovers, patient comes back home, and your family will help you to recover and integrate you back into the community. I'll finish here. Thank you very much.
Thank you very much, Najib. Please, are there any questions? Oh, so please, you can come to the middle and ask your questions. The communique that is going to come from this conference is going to be a whole textbook.
Thank you very much for your presentation. I have 2 questions. My first question is, because we have low coverage and we have a number of these private ambulance services creeping up, I wanted to know if we have any plans of collaborating with the private sector, because now we have issues where these private ambulances, they are not trained EMTs. Some of them, I don't even know what kind of training they have. They just transport very critically ill patients to us. And then because of the long waiting times at the ED, we end up losing a lot of these patients. So I want to know, because we have this poor coverage, if we could do some private sector collaboration, regulate them so that we can work well with them and then save more of Ghanaians who need access to ambulance service. So I wanted to know, what are our plans to collaborate with them? My second question, I'm primarily a staff of a regional hospital. And where I used to work, we deal a lot with private ambulances because of our challenges with the National Ambulance Service. My question really here is that, is it free? Because, yes, when we call the National Ambulance Service, a lot of Ghanaians believe that the service is free. But then we've had issues where you call the National Ambulance and relatives are supposed to fund their fuel to the referral center, and then it becomes a big fight. Please, is it free? And if it is not, we need standardized rates across the country, and we need it transparent, published, so that Ghanaians will know that it is not free, and then it is not a doctor who is charging them or asking them to take money. Thank you very much.
All right, thank you very much. So my boss is here with his permission. Answer. If he gives me permission, answer. Should I go ahead or you touch on? Okay. So you see, there are certain questions you just don't jump in and answer them. You understand? Yeah. So the first one is, obviously, I think when the conference started, it came out that we still don't have a regulator, right? Yeah, we actually need a regulator to regulate all ambulance services. So currently, we are partnering with a lot of the private ambulances in terms of providing coverage to mines and other people. And then we've had incidents whereby we contacted, I'm trying to remember some of the private hospitals. You know, they brought their people to our school, and we trained them, you know, as EMTs, and they are currently working with them. So we are encouraging that if you are a private hospital and then you have drivers, you know, and you want them trained, whenever we are training, we always open the scale and pick them in to train. I will leave the rest for my boss, and I'll touch on the issue of charging. You know, ideally, if there's a patient at hospital, a smaller hospital, and you want him at a bigger hospital, actually, that's not a response. That's a a transfer of care. So that is actually not regarded as like an emergency. So that's what we were doing, right? But then somebody who is sick in the house collapses. These are hardcore emergencies. But even along the line, you know, they give us some go-card and other things, and they are able to transport some of the cases within the region, you know, for free. So that's what I would say. I don't want to go into too much details and get trouble, but let me give my boss the...
Thank you. Yeah, so on the issue of regulation, National Ambulance is not a regulator. We are a service provider. Okay? So on the issue of regulation, there's an ambulance council. The act has been passed, but then the council has not been put in place. That is what I can say for now. But we can still collaborate with the private ambulance providers, maybe give them some training. But because they are not organized, you see, they are not organized into a group, it is very difficult to partner with them. But our doors are open. Our doors are open. Yeah. We can only do advocacy to bring on board the ambulance council, who will be mandated in regulating all the ambulance providers, even including us. Yes. On the issue of free transfer, whether ambulance service is free or not, you see, when you say something is free, it means somebody has the responsibility of paying for it. You see, here we are with very limited resources to provide entirely free ambulance service for everyone. So we've prioritized what we do. You see, so emergencies from the whole, emergencies from accident, emergency maternal cases, we do that for free. You see, but when we are to help do inter-hospital transfer, you see, we ask for support, not a fee. We don't charge a fee. We just ask for support. So for now, this is what I want to say. It's okay.
So please, the next question.
Okay, thank you. So my first point I want to make is when transporting patients to facilities, please, our personnel should take note that their life also matter. The overspeeding sometimes is just too much.
Very well
I do
noted.
travel with ambulance personnel sometimes when they are transporting patients, especially referrals. I do go with them. But then sometimes the speeding is too much.
Very well noted. Thank you.
So I want to ask this question. What is the focus when you are supposed to transport the patient? Is it getting there faster or getting there safely?
Right.
I think you are looking for an ultimate improved outcome for the patient and the safety of you, the patient, you and the patient, and everybody around you. You understand? Yeah, so that's what we are looking for, an improved outcome. We don't want to worsen the situation. If you can't do anything, keep them the way they are. That's it. Thank you.
And I think there'll be more information provided by the CEO tomorrow, and then there'll be another session on Saturday. The summary of the matter, stay tuned and stay around for the conference. Thank you. Yes, please.
All right, thank you for the question. I have two questions. The first one is very quick. I think for all the way in King Kenso Government Hospital, always
King
with
Kenso, the source where the paramedic training school is.
Exactly. But we are suffering from ambulance. We don't have the ambulance because our whole offense of the ambulance is not working now. So I wanted to know the whereabouts of that ambulance. That's the first one.
Right. Okay. Then the second one. Let's focus. Let's come to the second one.
Then the second one is with reference to how we refer cases. Our main referral point is cut. But anytime we call the ambulance, they say you have to get a response or feedback from Confanachi before
as is appropriate.
They come in. So I wanted to know if you still stand by that.
Right. So let's make matters very simple. We all know that ambulances are vehicles and they are machines, and machines are subject to wear and tear. So in as much as, yes, ambulances have been provided for each constituency, at any point in time, they are machines that might have to go for servicing, breakdown, etc.
But they
so
should
that
tell
might
us.
explain.
They should tell us. When they break down, they should tell us.
That might explain it, please. Even with those of us with our private cars, we know that the cars have to go for servicing, etc. Even we, the human beings, we go for servicing. So sometimes, in as much as I know it is very easy and it's very popular to bash the ambulance service, let's also consider that they are working with logistics that go through all these issues. And then, if I let you answer, I know it will become bloody. Then the other point about getting feedback from Confanoche, Director ICD is standing there. The referral policy has always been and will always be that the referring facility needs to communicate with the receiving facility. Otherwise, then what happens with the ambulances is they get stranded because when they come, we will seize their stretchers. And then somebody else will complain that their constituency ambulance, they are calling them, is not there. So then problem. So please, the referral policy, my bosses are the ones consulting on it. It is thick, it is concentrated. But these things are there for
the policy was made by human beings. It was made for human beings.
Yes.
So if the policy is not working, let's bring the human face to let it work.
Right. But
if you don't have digital to call and somebody is dying, exceptional cases, you should be able to accept. And then you educate them. Is that not so?
Okay. So please. So please, yes. So we are coming back to today's session. Thank you very much.
Okay.
I think we have one last question on the floor.
Thank you very much. Okay, I have 7 questions, but for the sake of time, I'll make them only 2.
Thank you very much for shortening them.
Yes. I think the first one is this last issue it wasn't part of my question, but the last issue of calling, if you don't call, we will not take. That's the standard practice. That's the standard practice. So why are they not calling? Or why that when they call, nobody picks? So we need to, I think we have to find solution so that if I call, I'm sure somebody will pick. And if somebody picks, it will give me a response that, oh, ABC, and come back in 2 hours. But many times, the response I have is that when we call, nobody picks. And then the EMT will also tell us, because I'm saying us because I'm the head of Ghana Health Service, that once the receiving end is not giving a response, we should also not come and pick the patient. The patient dies. And so I think we must find solution. This forum will give us solution. We have solution. And we must think through, because if you all stand, that's why I'm saying that the policy was made for human beings. If you all stand at that end, those receiving are feeling overwhelmed. And honestly, people are dumping on them, they go and die. Those who are also referring that they feel that they don't have the capacity to manage any longer. So they must move to the next level. So now, how do you address the case? I'm sure tomorrow, OKD and Prof. Manyami and Chris will help us. We need to find a system to talk to ourselves so that we will address it. Otherwise, I'm telling you, our relatives are dying because it's not your fault that you didn't receive because they were not called. But those over down to us having a challenge of not being able to communicate to appropriate people to give them the response. So I think tomorrow we will find a solution. But my question is, Dr. Usu ran away from the first one. I won't ask that payment issue. But so do you encourage hospitals to have their own ambulances? Because your fleet is not enough. And if you have our own ambulances, are you prepared to come and train the people in the ambulances to support you until you have a full fleet? Because at one point, your CEO we were discussing this. The fact is that when my hospitals start acquiring their ambulances, it means that we are shortchanging you. We won't give you that capacity to also bargain for the good pound from the government. And it's good, because when you are doing and somebody is also doing it, they won't give you that attention. But on the other hand, I was thinking that if your fleet is not enough for me, why can't I have hospitals buying their own ambulances and your people come and train us? So we support until you have the full fleet. It's something that I think if you don't have that, we can still discuss, because it's very, very important. Big hospitals have the ambulances. And I think what they need there is trained personnel to man the ambulances. And I've talked to CEO. There are many of you, I'm sorry, sometimes you don't have the ambulance to move. 1 week you are sitting down waiting. Why can't you assign it to hospitals that have ambulances during that time? Because he's still paying you anyway. To support. Until your fleet is available, then we pull you back. Thank you very much.
All right. First of all, you should buy the ambulance and donate it to us. Because we already have the men. So that will be the first answer to it. You say? Well, so anyway, that was on a lighter. Yeah, you can buy it and bring your guys or invite us. I know our CEO, he will listen and then he will send us. We will train your guys to man it.
That's exactly the case. But you know what? We have the men who have been trained, you see, to give treatment during transport. You see, nurses and doctors are not trained to give care during transport. You understand? They've been trained to give emergency care at the facility level. You understand? So legally, we have the mandate. You see, legally, we have the mandate. So if anything at all, you can get the ambulance, as Majid said. You see, you can buy the ambulance, you can train your people, but you can still give it to us to use it for you. That is all. You see, and the charges will come to us. You see, At the end of the day, we want the best outcome for our patients. That should be the ultimate aim. You see, that should be the ultimate aim. Yeah, so that is the answer I can give. We have the expertise and the mandate to care for patients during transport. Facilities by law do not have that mandate and training. Yes, that's where it should end. Yes. But we have the mandate.
Thank you very much. Please, a round of applause for paramedic specialist Majid. So please, you can come to the middle. Right, so please, we have our next session. The last session for the day, we want to remember some of our colleagues who have passed. And to help us, we have two very special presenters who will come up after we have gone through the slideshow. The first is Dr. Ruth Owusu-Entry, who is a fellow of the Ghana College of Physicians and Surgeons. She holds an international fellowship in forensic psychiatry from the Dalhousie University and Royal College of Physicians in Canada. She's a senior lecturer at the KNUST Medical School. I won't say it again, but you know, the best medical school, and also practices at the Komfanochi Teaching Hospital as a senior specialist and acting head of the Psychiatry Directorate. She's the medical director of Recovery Pathways, a renowned private clinic that specializes in mental health and employee assistance programs. She serves on the Ghana Medical Association Committee on Physician Mental Wellness. She has won several awards in her field of practice, including the 2019 International Fellowship of the Association of Women Psychiatrists in San Francisco, US, and the 2025 Millennium Excellence Awards in Ghana, both in recognition of her work towards women's mental health. She is a past and indeed the first female president of the Psychiatry Association of Ghana. She's a prolific conference speaker and a researcher with several publications and books to her credit. And to join her in our presentation for the Fallen Heroes, we have a giant in emergency medicine. When you think of emergency medicine in Ghana, there is one name that should definitely come to your mind, Dr. George Odro. He is a fellow, a surgeon of the fellow of the Royal College of Surgeons and a fellow of the Royal College of Emergency Medicine. In Ghana, he is considered the founding father of emergency medicine, the pioneer who brought the training to Ghana and trained our first 7 and subsequent cohorts of emergency physicians. He serves also as the course director for the Advanced Trauma Life Support faculty here in Ghana, and once again was the first person to bring the training here to Ghana. We all stand here as emergency physicians, emergency nurses, and as EMTs because of the work of this one man. So we will honor our fallen heroes and have a presentation by these two distinguished speakers. Thank you. So we remember these heroes for their passion, their dedication, and for their service to us and to their families. Amen. Please, with a round of applause, in fact, with a standing ovation, shall we welcome Dr. George Oduro to give us a presentation. Oh, please, let's keep clapping till he comes, please. We all are because he is.
Please be seated. Good afternoon. Forget everything that the young lady said about me. I am just a humble so-and-so, invited at the very last minute to share a few thoughts with this august crowd. I hope you can hear me from the back. Yeah. I suspect they did not even make allowance for me to use a microphone. So I came prepared. A few things that I have garnered this afternoon relate to engineering roads for safety. His data suggests, since I've been here for the last hour and a half, 9 people have died from road traffic accidents in this country. The gentleman that spoke about seeing safety I think his talk transitions neatly into what I'll be sharing with you in a few minutes. Because he made a big fanfare about seeing safety. Okay? Even to the point of saying, we don't want them to sweep us away so that we will die. Yeah. If we get burnt out, we are not being swept away so that we die in the next few minutes. We're being swept away gradually, persistently, over weeks, over months, into depressive behavior and so on. We will gradually lose resilience. We will become unsafe to look after people who have emergency problems. In 1657, Blaise Pascal, remember him? Blaise Pascal said, I would have written a shorter speech, but because of the notice I was given, I did not have the time to make it any shorter than what I thought. So you will excuse me if I eat it to her time. What I think we will be doing this afternoon, I'll be speaking from the podium because I saw some people have difficulty with their equipment. I haven't tried it yet. Oh, really? Right. Koima. Right, so shall we try and see if that works?
Okay, it's working.
Yeah. Okay. So, this is the speech I was going to make for you. 40 pages of it. I think some people may line up there and wait to give me a knock on the head if I do all the 40 pages. Remember what I said about Blaise Pascal? That if I would have had the time, I should have made it shorter. Today is all about you, really. Staying safe, being well. You don't want to be looking after somebody who is sitting on their couch eating fufu and thinking, Brahma Bray, this chap is, he's feeling better than I am, okay? A section of it will be interactive. So if you want to, you can actually move in front. There are plenty of seats in front. Bring your humor along, because that way we can all remember what it is we're going to talk about. You have to be humorous to work in emergency medicine. It's the only department, it's the only discipline in which if you cannot laugh, you cannot last. A patient is shouting, another patient is fitting. And even if you are sitting on the, excuse me to say, the toilet seat, the nurse is saying, can you sign this for me? So a bit of humor is not just entertainment. For us, it is something which is life-giving. Right. So can we have maybe a show of hands? People who lead us through very quickly, who work in the emergency field, either as EMTs, as emergency nurses, physicians, or even as a lay person. What stresses you when you're looking after emergency patients? Because if you don't volunteer, I'll volunteer you. Yes, please. Yeah.
You take your time to take care of the patients, and then when you get to the hospital, they tell you there's no bed.
Oh, that's just below the belt. What's his name? I think he was called Mr. Opoku. He went from La Hospital to Tema, Lekma to finally ended up in, I don't know where, 7 hospitals. And he died. Any more stresses? Stressors?
All right, Doc.
Yes, sir.
I think the most stressful one is taking care of a patient who is restless or aggressive. And you can see the patient is bleeding. You need to do something to stop the bleeding, but the patient is not stable. You are trying your best. You need to strap the patient. The patient is not giving the chance. And at times, if you are not careful, they can even vomit or spit into your face. So those ones are sometimes stressful.
And the vomit contains blood these days.
Yeah.
Yeah, any others?
What stresses
Quick,
me
otherwise
the
we
most?
won't listen to the
What
next person.
stresses me the most is you not getting logistics or things to work with.
Right.
Yeah.
So you're talking about gauze swabs, IV fluids,
Instruments.
instruments, pulse oximeters, monitors. I shouldn't be saying this. I'm retired now. You should be saying it. Otherwise, and you see the people who can do something about it, they are sitting in front. But if you don't say it, it's like, well, all quiet on the Western Front, isn't it? Any others? Okay. The thing is that they say about it, go, Linda. Otherwise, I'll sing your song. Carry on.
Okay, what stresses me is when you have come to work, charge is full, all the other units is full, and then the wards are also full. There are no beds. Yeah. Already you've not started work, but the scene alone distresses you.
You want to run back home and curl up in bed, not so. Yeah.
The most stressful thing is when you run a code on a patient for almost 20 minutes, you have achieved ROSC, and then the next minute, another code again.
Yeah, lady in blue.
Please, what stresses me is maybe 2, 3, 4 relatives around you asking, what to say? Hey,
Mrs.
Thank you.
Yeah, so I thought you guys would give your own selves your lecture. Okay. The things which stresses us, and they don't change. 2 months ago, I was with fellows from the Royal College of England. A week and a half ago, I was in Nigeria, in Lagos. And in most emergency departments, this would be the sort of list of things you see. The ECG printer not working, limbs not working, no bed syndrome, overcrowding, angry relatives who are not grateful, and so on. Or even patients who are not grateful. And worse, as he said, you get a return of spontaneous circulation. You think you finished for the day, you finished your stress for the day, and there is another code, okay? What about system stress source? Because if you lived and worked in the kind of environment that Majid said, that the engineer said the roads are all bypassing the towns and so on, you probably wouldn't have system stressors. You've mentioned some equipment failures. What other stressors can you think about? Right, silence. Anyway, it means everything is fine, kosher, as they say. How does stress show up in your practice? Again, volunteers. Whenever it says Q, question, it means yes. Hunger and fatigue. Oh, anger.
Anger. And
well, a hungry man is an angry man.
And fatigue.
And fatigue, yeah. How else? A lack of interest, as in yourself, in the in the work, from somebody else, from the managers. But who is lacking the interest? Right, okay. So, because of persistent stress, which you cannot relieve, you start to lose interest in the work, in the important work that you're meant to do. Right? Any others? Shh. Do you write the mistakes? So some mistakes may be made. A patient is supposed to have 5 milligrams of morphine, but somebody gives 50. You don't write it down. Right, okay. Yeah. Some people fake sickness, though. They say, what am I going to do today? Go back into that maelstrom again today. Let me ring in sick. But it's true, it actually affects your immunity. We'll talk about that in a minute. Any others? Right, okay. So frustration, depression, a giving up of hope. A patient says, I have a sense of impending doom. And you think, you don't know what I'm going through. Anybody ever felt empty? I said, what is the meaning of all this? Why do I have to get up every day and come into this? Because they all know, those who are sitting in front, what the problem is. But they will do something about it tomorrow. And tomorrow never comes. I'm not picking up on the people in front, don't worry. This is a problem that's common to all of us. It's actually a problem on which I have thought long and deeply. Okay, because when I joined the faculty a decade or so ago, I used to think having a structured approach to looking after sick and injured patients is common sense. It should be something that we don't have to argue about at all, or even hold conferences. That you should be able to convince any reasonable person quickly and easily that this is a good way to institute the care of emergency patients. I'm being warned that I don't have a lot of time. Right. So the depression you talked about, the irritability, the anger, the hunger, the lack of interest, they end up in a condition called burnout. Okay. And the emergency room and emergency circumstances, they actually trigger a stress of fight, fright, or flight. And you have to congratulate me on Asante saying fight, fright, flight. Response, okay? The thing is that, yes, and response, yeah. The thing is that all this chaos and uncertainty and the night shifts, which hasn't been mentioned, the clinical load. Somebody told me about KDK in the emergency room. Okay, they will ring you even when you are least disposed to taking the phone call, and they'll say, my relative is, and so on. They cause high cortisol, poor sleep. And somebody mentioned weakened immunity. So, have you noticed that when you go on leave, that's when you get sick? Yeah. Because you've been trying to cope. And then all that breaks down. But how do you cope? How do you relieve stress? Yawn. That's a good one, yeah. Anybody else? How you relieve stress? You cry. Yeah, that's a good one. Being emotional. Letting it all hang out. Anything else? I know somebody, I wouldn't mention the name. I can see them somewhere in here. They eat fufu at 11 p.m. every night. So people have different ways of coping, you see. And they will try and apply those. The thing is that, and these other systems, some people will pray even before they will wear a cap. TikTok videos, WhatsApp groups. So there are plenty of avenues. The trouble is this, that you will do this at the end of the day, and then tomorrow you go and face the same problem, and again the same problem, and again the same problem. So it's the duration of it which brings about that burnt out feeling of hopelessness and so on. Are there any support systems in place that you know about? I know in the emergency department in Konfonoche that yes, they have mentors, for instance, so you can go and talk to them, even about your cash problems, because some of the physicians are very rich. Yeah. If you have a gambling problem, they may mentor you, and so on. So, high stress environment. Some people sort of divert into other things which give them pleasure, like alcohol, and so on, and gambling. And if the department or the institution has a sort of a rational, structured way, then that can also help. Okay. We say tikro and kwejina for that reason. So family, friends, colleagues, faith groups, and so on. This one, maybe we can get two people to tell us what one change, and then maybe we can all take it home, or you can add it to your famous communique. What one change would reduce 50% of the stress that you guys face? Assuming, well, so put it in a communique. Assuming I could do something about it. Yeah, so briefly, the solutions to talk about include micro-recovery. So in between patients, try and take a few deep breaths before you continue. Set boundaries. If Dr. Nyame says, we don't have enough people to do this shift, so you have to do 4 nights in a row, tell him, no. Night shifts, Dr. Rose said, night shifts, they deplete dopamine in your brain. You have to find a reason why you don't want to do more shifts than you really should, because one shift is bad enough, but if they want to add plenty more, okay. And we know now that sleep is very important for a lot of physiology. Okay. So system solutions might include things like adequate staffing with good skill mix, scheduling that respects human physiology. We talked about sleep, protected breaks, so and so on. Okay. Right. That's not quite 40 pages, but it probably gives you a flavor of what I might have said if I had been given enough time. So, repeated physiological insults of stress can lead to burnout, which can be summed up as a loss of yourself, of the raison d'etre, as the French might say, a meaning to why do I want to wake up, have a bath, dress, and go to this hell. That is work, okay? Your well-being matters, because they said, do not become a second victim. So by the roadside, it's easy to identify that. In the fractious working environment, it's easy to forget that your taking care of yourself is actually a very important part of taking care of people who are anxious and unwell and sick and poorly. Okay. Resilience is a practice. It's not done in 5 minutes. It's a culture and a lifestyle. Okay. So we talked on what stresses us, what the impact of stress on us is briefly described what burnt out is, so talked about how we cope, how we support ourselves, how the system supports us. And thank you very much.
Thank you very much, Dr. Odro. So please, if you have any questions, please note them down. We'll have our second presentation by Dr. Owusu Entry, and then we'll address all the questions together. Thank you.
Hello, good evening, everyone. Thank you so much for inviting me to participate in this very important gathering. I was given 20 minutes. I said it was short because I talk for a living. And unfortunately, I have to cut short my talking this evening. So I will try to actually do less than my allotted 20 minutes because I don't want to further stress anybody. My job here is to make sure that we leave here distressed or find better means to distress. I'll use just maybe 2 to 3 minutes of my time for us to get up. Just mingle amongst ourselves quickly. Can we just do that? Look around, smile to somebody and make an eye contact. Make a deliberate effort to smile at somebody. Make an eye contact. Hello. It is not an opportunity for you to leave. You can decide to hug someone. Thank you, thank you, thank you, thank you very much. Can we please have our seats? Can we have our seats, please? Thank you very much. So I will quickly talk about the effect of poor mental health or welfare. Dr. Odro has done a lot of work in most of the things I was going to talk about, so I would go really fast on some of the evidence-based interventions to build resilience and reduce our stress levels. How we can create a culture of openness and psychological safety. What leadership and organizational role is in this appeal, and then I'll conclude. I'm sure we all know why we must talk about this matter. These pictures are from Confanochi A&E. There are 3 pictures I have put together. Probably some olden past time. But if you look at this picture, it immediately gives you an idea how the emergency setting is. If we don't talk about our welfare and our mental health, and we come to work to this chaos, noisy, unpredictable environment all the time, we can be sure that we'll break down. We work in environments that high acuity is important, and yet we have to make rapid decisions. We are frequently exposed to trauma. Many a times, we come into contact with violent patients. Those are my people. A few months ago, I was away when one of head of Grace told me that some people were held hostage at the emergency. Even hearing it was very scary. And another reason why we must talk about this is that you might have known or heard that WHO had said 1 out of every 4 people will suffer from mental illness at some point in their lifetime. Well, statistics has changed. A most recent one that was published in 2023 in Lancet Psychiatry says that now 1 out of every 2. This study was conducted by a group of researchers in Harvard. Now 1 out of every 2. And so half of the world's population will experience some mental disorder or some mental breakdown at some point in their lifetime. And that is scary. When the statistics was at 1 out of 4, around that time, my boss, Professor Akwesi Osa, and some colleagues had conducted a research in Ghana and concluded that in Ghana, it was about 49.6% of Ghanaians were moderately to severely stressed. So when the world was at 1 out of 4, Ghanaians were almost at 1 out of 2. Now the world is at 1 out of 2. I don't know where we are at now. As we go on, we will learn that stress is the leading risk factor for mental breakdown. And so if almost 50% of Ghanaians are moderately to severely stressed, it is a very sorry state we find ourselves in. Researchers define welfare as a way of self-care where an individual takes time to do things that help them live well and improve on their health. And now you know that health is in 4 modalities: physical, mental, social, and spiritual health. If we fail to take care of ourselves, if we fail to maintain our mental well-being, what happens? We begin to build up stress. Now, don't get me wrong, stress in itself is not wrong. There is eustress and there is distress. For some people, they work better under stress. For some people, without stress, they will not study for that exams. For some people, without stress, they will not hurry up and get to work and finish their tasks. But it is when you take more than necessary, more than your body can take, that it becomes a problem. And when we do not take care of ourselves, we build one stress upon the other, one stress upon the other, and sometimes it is the tiniest stress that topples us over. When nothing is done at this stage, we move to what we call burnout. Now you are buried under the distress that your body physically, mentally is actually crying for help. You become numb, mostly emotionally. You are making mistakes, and I'll go through some of the symptoms that we show at this stage. There are other times that when we do not take care of ourselves, we develop compassion fatigue. People become socially and emotionally disengaged. So they have brought an emergency case, accident case, and you are an emergency medical care practitioner, and then it's like, you can't be bothered. No sign of urgency, no sense of urgency. You are totally numb psychologically, emotionally. The worst of things that can happen to you if you do not manage your stress well is now to fall into full mental breakdown or mental disorder. And I have already explained that now it's becoming scary. Mental health practitioners like myself have consistently preached, take away the stigma, seek help. I feel the floodgates are open, the people that are thronging into our department, sometimes you get to work, medical students, they've all lined up. All sorts of people, staff, colleagues, and all of that. We are not saying that be discouraged from seeking help, but this is showing the reality that people are not taking good care of themselves. There are several signs and symptoms of stress, and I always say that these are not cast in stones. It's important to identify your indication that you are stressed. I know mine. You should know yours. There are times when you know you get stressed, you get headache, one-sided. There are times when you get stressed, you just can't sleep. There are times you get stressed and you are irritable. When I get stressed, my eyelids keep blinking and I have to stop everything and go and sleep or do something to distress. You should know when you have gotten to your limit. Other people experience back pain, aches and pain, palpitations, unexpected hair loss, etc. Yes, you go to the salon, they comb your hair and everything pulls out. Mentally, people lose focus, they keep making mistakes. I've talked about sleep changes, there is appetite changes, reduced libido, and all of that. Can be indications that people are building more stress than necessary. But that is not all. When people have not taken care of themselves and they let stress build up, they go into burnout, sometimes these symptoms persist for some days. If you're able to get help quickly, you probably are at the acute stress syndrome phase that you can quickly recover from all the symptoms. But most of us keep telling ourselves, oh, I'll get over it, I'll wait, I'll soon go on leave. And we keep postponing getting help. When you see a cardiologist with a first heart attack and you survive, what do? They make sure that you are the experts. They have put you on statins, they've put you on whatever, aspirin. They are doing everything to prevent another heart attack. In the same way, if you begin to experience any symptoms that indicate that you are in distress or you are in high levels of stress, you would have to put in a lot of measures to prevent a brain attack or a brain breakdown. Some people, beyond post-traumatic stress disorder, will develop depression, substance misuse problems. People get into addiction problems, especially now the behavioral addictions. There are most of our health care professionals that are struggling with gambling and betting, and they are losing it. Waton the fear, waton the car, the wedding, sika wedi, I didn't I my bet. And yet they can't bring themselves to stop. Of course, physical health challenges are also part, and so you get overly stressed. It's not only your mental health that is affected, your physical health as well. We know how these things are connected, that stress is not just a psychological phenomenon, but it is actually a physiological phenomenon as well. There are people that their spiritual health becomes affected. They begin to lose faith and feel abandoned by God. In fact, they get to existential crisis that today I am here, tomorrow I'm gone. What's the essence of being alive? Because they have seen a colleague pass away at the emergency and they were so traumatized that they did not do anything about it. So they begin to push to or move into floating mode. After all, I'm here today, tomorrow I'm gone. So they begin to live their lives anyhow. If we can't withstand stress and deal better with it, it means that we have to build resilience. It means that we need to adapt, we need to recover, and we need to grow after there are any stresses or adversities. And that is called resilience. Resilience is not a one-time occurrence. It is a dynamic, multifactorial process, and it involves a number of domains. I will touch quickly on some of them. The first aspect is the emotional resilience skills. Our job as emergency medical care practitioners involve a lot of uncertainties. So if you are somebody who would always want to plan your day and know what to expect, then you will always struggle. Build yourself and create your mind to tolerate uncertainties because of the nature or the unique nature of your work. Practice self-compassion. Be gentle and kind to yourself. Sometimes you make mistakes. Don't let it overburden you and be very guilty and overburden yourself with that mistake. It might have even resulted in the loss of life. But ask yourself, if you knew that was a mistake, would you have deliberately killed somebody? No. Balance empathy with emotional boundaries. Recognize when emotional numbing is protective versus when it is harmful. I said that there are times that you come across emergency situations that you quickly have to switch momentarily to become emotionally numb. And yeah, fair na ya de mami bini ne ma omu nyina ewu accident wu besu. We emergency care practitioner. Quickly, your job is to take care of them and make sure that whatever you can do to restore their lives, you do it. And so you would need to learn to switch in between. Emotional numbing is a problem when it becomes long-term and consistent. That time, you get into compassion fatigue. But in the line of your job, you would need to learn to switch in and out of emotional numbness to be able to do your work effectively. When you switch, please do return to normalcy. Physical resilience skills, very important. What kind of foods are you eating? Do you go to work on an empty stomach and stay empty the whole day? Please, you are doing yourself. If you do that, it is not your grandmother in the village doing you. You are doing yourself. Find good food to eat. Keep a bottle of water in your scrap pocket or close by and be sipping on it throughout your shift. Regular movement and exercise. Thankfully, your job involves a lot of movement, so that is good. And then it's very important to take micro breaks, and these are micro. It can be just 3 minutes. Sit down and breathe in and out. Sit down, just do a quick check on Facebook, laugh at something, and come back. Very, very brief breaks. Manage your work-life boundaries and protect your time offs. I know somebody, the person is here, off in a hospital. Please, when you are off, stay away from the work environment and make sure that you are resting. It's important. And one of the things that helps you to switch off from work mood to personal time is to develop some rituals to mark your end of shift. Very simple things like, yes, handover. If you can, and I would advocate for that, change your scrubs into your personal clothes. Don't go home still in your uniform that you worked in. Put off your computer. Shut down your computer or sign out of your computer and make a deliberate effort to say good night or bye-bye to your colleagues so that they know you are gone. I don't see why you have formally closed from your shift and you are sneaking out. I mean, for what? Say bye-bye, Charlie, see you tomorrow, I'm off, good night, enjoy your shift, so that psychologically you have ended, okay? You have signed off, so you go home in another shift. Some people routinely develop techniques like right after work every day, they'll take a long shower, or right from work, they go into the gym. Get something routine that your mind appreciates consistently, that, look, work has ended. I have moved into me time mood. Also build personal stress prevention plan. Identify what your personal triggers are. Mark stress peak times during your shifts and identify them for subsequent shifts. You can do pre-shift routine. Somebody said when they enter the triage and they see how many people are gathered there, immediately they become stressed or distressed. Yes, when you are going into your shift, you can develop some pre-shift routines like priming yourself that, okay, I have moved from home into the chaos, into work. For the next 12 hours or for the next 10 hours, I am in this business. Consciously prepare your mind so that your mind is not struggling with, I don't want to be here, but I have to be here. That in itself is very stressful. And I talked about the post-shift decompression habits we can do. Avoid caffeinated drinks. just to keep alert and awake. It would mask your stress symptoms so that you don't get an opportunity to distress. Okay, and then sleep hygiene. If you want to sleep well, try sleep hygiene techniques first before you move to any sleep medications. Simple things like putting off your light before you sleep, making sure that you have made your bed. There are some of us, especially the gentlemen, and especially those who are single, half of their bed is maybe their wardrobe or their bookshelf or something else. Poor sleeping environment in itself can prevent good sleep. And when people want to sleep and they are constantly on their gadgets, it is a counterproductive process. That there is a biological switch in our brains that when there is light around, puts the sleep at awake mood or puts us in awake mood. If there is darkness, the sleep shifts or the sleep switch shifts to sleep mode. And so here you are lying on your bed, trying to sleep and still throwing light into your eyes. Your body is widely awake, struggling with you wanting to sleep. Even if you fall asleep, what happens is that you don't get to go to the deepest portions of sleep. There are 5 stages of sleep. So people linger around stage 1 to 2 every day, and they don't get rested. The point that you get rested and restored is when you're able to go to 4 and 5 stages of sleep. Rapid on-site stress management. If you are at the workplace and you get distressed about something, there's a very bad case that comes and you quickly feel distressed. What are some of the things you do? 4-7-8 breathing techniques. It is taking in, breathing in for 4 seconds, holding the breath for 7 seconds, and then letting it out over 8 seconds. You can practice it and let it become second nature. And when you do it repeatedly, maybe 3-4 times, it has a way of calming you down. There are other grounding techniques like the 5-4, 3-2-1, when you immediately keep quiet and feel grounded, begin to feel your environment. It helps when you're actually at the end of your shift. Because of time, I wish we practiced some of these things, but I would have to run through them. And then brief cognitive reframing. Consciously telling yourself that, look, I can handle this. I have just 10 minutes to the end of my shift. It's just 1 hour for me to close. You conscientize yourself, and then you bury yourself in the work before you close. There are times we find ourselves in very high stress moments. What can you do during those moments? Avoid catastrophic thinking. Shift from, what is happening? What can I do about this? Rather quickly choose to think, what can I do right now? And I call that time cognitive triaging. As emergency care, medical care practitioners, we do triaging most of the time. And with our mental well-being, we have to constantly prioritize the decisions we need to take when we are in very, very demanding and highly stressed moments. I call cognitive triaging. Peer support is a protective factor, and I say that our colleagues are our psychological PPEs. You have no idea what your colleague can do to help you. When I deal with institutions that I provide EAP, one of the very simple things I tell the HR, put in place what we call the buddy system. Buddy system is simply identifying somebody to say that, look, watch my back, I watch your back. You know how our culture is when, if you tell somebody that Charlene and say, I don't see you well, they get offended and think that they all can't see my body, kind of thing. So in the buddy system, you are giving your colleague an opportunity to tell you when on who ye. And it is vice versa. So that you don't get angry when they have told you, Nancy, you are constantly late at work. Nancy, you are moody. Nancy, you have become withdrawn. Give somebody the permission to draw your attention to when you are getting tripped over. So activate the buddy system, especially on difficult shifts, brief check-ins during the shift, debriefing after critical incidents, and then building a resilience team culture by normalizing talking about stress. Chale, my stress though, chale, she say the team crash. It should not be big when I be, oh, and you take the day off. I went for leave one time, and my lead clinician I handed over to said, oh, you are coming back to work tomorrow. I said, yes, but I did not get an opportunity to rest this leave. I said, oh, boss, for 3 days, we made here chairman. That statement alone was so refreshing. I'm like, wow. And indeed, he took over my duties for that 3 days. And then it was now that I was actually properly rested. Why can't you do that for your colleague? What can the institution do? Adequate staffing and workflow design. Now I hear HOD says there are so many medical officers. Makachi and Cross on breast psychiatry. But it should not be a one-time thing. It should be consistent. The management members who are part of this team, let's ensure that there's adequate staffing. Dr. Dro added with all the different mix or cadre of staff so that people don't get overloaded. We should provide for our people adequate access to confidential mental health services. Every year, psychiatry units organize what we call the mental health school. And we provide free distressing strategies. Come and sit down, sip and paint. We take you through art therapy, relaxation. Obiamba, they are busy working. And then when we have finished and they have heard how things went, come and do some for us. Now, when you call us to come to your department, we charge you huge money for you to distress. Let's provide safe space for restorative breaks. I wish that even in the midst of constrained space, there can be just one small room with some artifact of some waterfall or some dim light with small calm music that when people have had really a bad day, they can just go and sit there and cool down. I don't know whether it can be done, but I really encourage you to do that. And then, as part of what we can do, opportunities for group chilling. We are going on a trip. Please encourage it. And when they set it up, don't take yourself out. I'll leave us with 10 commandments of mental wellness. Commandment 1 says that thou shalt not expect someone else to reduce your stress. Commandment 2 says that thou shalt not resist change. Third commandment says that thou shalt not look down on thyself. Commandment 4, remember your purpose on earth and work towards it. 5, honor thy limits. Sixth commandment, thou shalt not work alone, delegate. Seventh commandment, reduce maladaptive coping mechanisms like drinking alcohol and smoking. Eighth commandment, thou shalt not work harder, thou shalt work smarter. Ninth commandment, seek to find joy and mastery in thy work. And the 10th commandment says that thou shalt continue to learn. In conclusion, I want to say that never become so busy making a living that you forget to live. Thank you very much for your attention.
Thank you very much, Dr. Wusuenchi. So please, any questions, comments, or contributions? We have about 5 minutes for questions, comments, and contributions.
Yeah, so my question goes to Dr. Ruth Wusuenchi. You mentioned that stress is like a spectrum. So from stress, burnt out, then to mental illness. So is it like, can you, when you go up there, can you come down? Or there is or there is a point of no return?
So it's not a journey of no return, but the higher you go, the more difficult it is to return. When you move from distress back down, it's easier. When you move further up to burnout, it's more difficult. When you get to mental illness, you need to actually take days off work, longer days off work and all that, probably be on medications and all that. So it is not a journey of no return, but the further you go, the more difficult, the more engaging, the more costly it is to return.
All right, so my question is, it comes with a scenario. I think.
So, please, you have a.
Yeah, very short, very short. So I was sitting in the car with someone, and the person was talking to himself. You know, so he just saw me and he said, in tree, miniscal. That's what the person said. So in a financial stress, it's when it comes to the financial stress. With reference to your 10 commandments, you said, thou shalt not expect someone to reduce your stress. So with this person, when he comes to you, I don't know what you are going to tell that person, knowing the cause of the stress.
I have usually told people that it's better to teach people how to fish than to give them fish. You give them money today, tomorrow it will get finished, they will come for more. As a starter, you may give something, but it can be a sustainable way of reducing their stress. What's your background? What certificate do you hold? How can I help you get a job? So that they get consistent flow of money. It's a way that they themselves will reduce their stress, okay, when it is financial stress. And it will apply to all other areas of stress. Don't wait for your head of department to take you on an outing, or don't wait for your boyfriend to take you on a date. Don't wait for your birthday or for Valentine's. Charlie Kotina, Lancaster, never will be keke. You know, it is not any occasion. What Gary, your friend is saying, how's a cocoa and no pebia sa oko golden bean and I say Lancaster, they do buffet breakfast. Nebo on sheda nyedi. Be at 250, 300. One day be na cheaper crown. One day be then you go and treat yourself. Okay, so please, it's our responsibility first.
My question goes to Dr. George Odro. I never had an opportunity to ask him a question. Today I'm asking him a question. You dare ask him a question when you don't have answers. He throw back to you. So you always try not to ask questions because he asks you, Lawrence, what are you asking me? What do you think? Doctor, don't throw it back to me this time. We shouldn't wait for tomorrow to face some of the things that stress us. That's the lesson I learned. Because the answers are here. If you wait for tomorrow, tomorrow will never come. So looking back, after 10 years, there are some things we are still waiting for. And I really want to know, what's the way forward? Because 10 years we spoke about them, and we are still speaking about them. Now, what do we do? Maybe you can advise us. Because sometimes it's better when you move out of the system and sit back, you see it better than those of us who are still in the system. Thank you very much.
It really is a difficult question, isn't it? And if it wasn't, I'm sure we would have found a solution by now. Somebody who will remain nameless. In earlier days, when I would sort of fly off at an angle, almost irate, and say, the department is not safe, would reply to me, Ejuma edin de bopa. That was obviously, I felt inconsiderate. But I think over time, one has come to a certain realization that even an engagement such as we are involved in at this time contributes to the steps necessary to improve emergency care. One has come to the realization that while these things may not happen within 10 years, or perhaps even within 50, when I'll be long and truly gone, that the fact that we persist in even bringing the matter up is in itself an indication of progress. There are a number of easy, low-hanging fruits that we tend to miss. And when I have looked at the program, such as Dr. Forson shared with me, I think there is actually a section on artificial intelligence. And I'm thinking, you probably want to crawl before you learn to run. Because you see, in Majib's talk, and also with the engineer's talk, one very big hiatus that we have, and which I consider a low-hanging fruit, is actually data, which can be collected relatively easily. Sometimes in formal research, but usually in simpler activities like audit, clinical audit, which may show that if there is, for instance, a delay in a patient progressing down their clinical pathway, from home being picked up by an ambulance waiting in the emergency room, in front of the emergency room for so long, coming to the ED, waiting to be handed over, waiting to go to X-ray. I think by this stage, those ones we should really be getting on top of. They shouldn't cost an arm and a leg. And some 9 or 10 years ago, when I was honored to give a lecture to the Ghana College of Physicians and Surgeons, I remember at that time quoting the Vice President, John Dramani Mahama. Obviously, time has moved on, so he's the president. And he had said, there is no flesh on the bones. A simple truth is that there are things that we should do, that we can do, which do not necessarily involve money. Obviously, if we get the money in our pockets, we are happy. As one of my friends used to say, no, complain about when we asked him anything, I was no. So those ones will not come easily. But I dare say that at meetings like this, if we put our heads together, we can, as a responsible, reasonable group, come up with low-hanging fruits in the communique. Obviously, if you write in a communique saying, we have deliberated for a week, and we've come to the conclusion that the government should build a trauma one center in each of the 16 regions. It may be well received, but the wherewithal to do that will be difficult to come by. There are easier solutions which will work in a non-partisan way to actually improve care for all our people. And when I say for all our people, I actually mean for ourselves. Because if you live here, in this country, in terms of healthcare delivery for each one of us over that lifetime where 50% have a mental health predisposition. Each one of us has 2 places of contact with the healthcare system. One being the mortuary, and the second being emergency care.
Thank you very much. So, in the absence of any other questions or comments, contributions, thank you all so much for staying with us for day 1 of the second EMSOG conference. We are very pleased and glad that you were able to join us today for our plenary sessions, our opening ceremony, and our panel discussion. Tomorrow for day 2, we start at 8:30. We will start with an audiovisual reflection of everything that has gone on today. We have a plenary session by our very own Dr. George Owusu, CEO of the National Ambulance Service. So all the questions, all the issues that we had about ambulance pre-hospital care, please, we can start writing our books and our compendiums. Tomorrow, the best person to address them will be given the chance to speak. We will also have a plenary on the role of emergency medical care in pandemic preparedness in the setting of emergency response by Dr. Joseph Boni. We will have another panel discussion. Then we'll have 2 workshops, including one on AI in emergency care, and then an introduction to the essential emergency and critical care concepts by the WHO. We will have our oral abstract sessions, and then a symposium in the late afternoon on women in emergency medical care, leadership, and equity. As we are ending for the day, please make it a point to pass by our exhibition hall. We have our abstracts, our research abstracts that have been presented by residents from Kolebu Teaching Hospital, Konfanochi Teaching Hospital, and the University of Ghana Medical Center. At this point, we would like to call, as we started the day with a word of prayer, we would like to call Reverend Daniel Opuni to give us a closing prayer to end the day. Thank you.
Please, respectfully, can we be on our feet? Let us pray. Our Heavenly Father, we thank you for a day that like this unto us to meet and to talk and discuss things concerning health, especially emergency health. We thank you for a good day. We ask for a restful evening and a safe trip to our various homes. Renew our strength for the days ahead of us. We thank you in the mighty name of Jesus. Amen.
Thank you all very much, and please have a safe journey home or wherever else you are going.